So to everybody, welcome. My name is Demian Szyld. I'm the Senior Director at the Institute for Medical Simulation at the Center for Medical Simulation. And as many of you might know, we're an independent nonprofit based at the center of the Harvard healthcare system. We do a number of things, including teamwork training and crisis resource management, particularly around intact teams in OB and anesthesia. We also serve as consultants to organizations in a program called the Affiliations Program. And near and dear to my heart, work that I do is leading the Institute, which has to do with faculty development, instructor training, capacity development, and increasingly customized consulting. During the COVID period, we initiated this series called the weekly webinars because we wanted to remain connected and learning internationally with all of our colleagues and affiliates. And that proved quite hard during the travel ban. That's thankfully getting somewhat better. And yet we are just excited and leveraging the new formats that are available and making this kind of a session possible. So I'm really happy to have Sarah Janssens here, a friend and colleague from Australia. She's participated as a fellow at the Center for Medical Simulation for 6 months, and that's when we really got to work together and learn. And a lot of what she's going to be talking to us today about came out of that work. So fitting that we have you back and that we don't have to wait until the travel ban reopens. I'll say a few more introductory words, and then I'll just invite you and everyone else here to get involved in the conversation. The weekly webinar series is available as a recorded basis, so please feel free to check out our program and also come back as we're planning on continuing it. And we have a number of different formats, including Ask Anything format. So next week we'll have an open panel discussion with the CMS faculty. We have Meet the Authors sessions like this one, where we get to talk to the current and future voices in the field of healthcare simulation and safety. And we also have panels and keynotes and specialized workshops. So lots of opportunities for the community to keep on learning and connecting together. So I know we have formal objectives for the session here, but aside from that, Sarah, I thought I would just ask you to share a bit with all of us about your background and where you're working, how you got to doing all of this. Turn it over to you. I know you have a couple of slides prepared, so.
Yeah, I'll see if I can share my screen. Here we go. Thanks, Damian. Thank you so much for the invitation. It's really a pleasure to be able to connect with you guys again. We're kind of geographically on the other side of the world, but I kind of in some ways feel like I never left Boston, just with that ongoing, I guess, relationship that we have with you guys. So I think some of the people online are my friends, so they probably know me already. But for those of you who don't, I am an obstetrician and gynecologist, and I work at the Mater Mothers Hospital in Brisbane. And I'm also the clinical simulation director for Mater's Mater Education, so taking a role in faculty development and our simulation fellows program here at Mater. I'm also lucky enough to chair a group with our ONG college with respect to simulation and advising college regarding that. And as mentioned, a lot of the work that this research that I'm doing is part of my PhD, which I'm doing through Monash University in Melbourne. And I do have to disclose that I've been very lucky enough to receive some funding to support my research, which is not cash to me, but it gave me some clinical backfill to allow me to be a clinician researcher. So very, I guess, thankful to the Mater Foundation for that opportunity.
Sarah, thank you for introducing yourself. And as you get started, I'll let you know that we have folks on joining live today from Argentina, Australia, Brazil, Latvia, Nepal, Saudi Arabia, Spain, Thailand, the UAE, the UK, and the US of A. I think that might be a record for us in terms of the number of people here. For you who are joining internationally, I wanted to invite you to interact with myself and with Sarah throughout the presentation. The best way to do that is through the Q&A button, which you have available there. It's Q&A is questions and answers, but we can use it liberally. Feel free to introduce yourself and your background. And throughout the presentation, let us know what you're thinking, how you're reacting. I know Sarah wants this to be conversational, and so I'll be here with her talking about her topic and also bringing to her your comments and questions. So I'll be your avatar for the day. So feel free to use me there.
Thanks, Demian. I really do want to hear from those around the world how this resonates with you guys. So that would be great if we could get lots of questions or comments or whatever. I thought it might help a little bit just to explain the context of where I work. And as I said, it's an Australian context. We are at probably the busiest maternity hospital in Australia. We have about 10 to 11,000 births a year. And we have a mix of public and private patients and an 80-bed NICU and about 200 maternal beds. So quite a busy hospital. And just a reminder to our international colleagues, I suppose, that in Australia, we do have a very British model of healthcare and maternity care. So when I say midwife, midwives in Australia play the role or perform the role of not only midwives that you might have in your context in America with doing the births and providing antenatal care, but also work as obstetric nurses and provide that nursing support and care throughout labour and delivery. So when I speak about midwives, I'm sort of in some ways conflating an obstetric nurse and a midwife together in some form. So just as a little kind of cultural difference, I suppose, between that UK or British system and other systems around the world in childbirth.
That's so helpful. And I know you asked me, Sarah, in preparation that I help make sure our conversation is both international and global, but also bringing some of the other context as an emergency physician and someone who's worked in different practice settings. So hopefully all that will make it international and celebratory and interesting to a lot of folks.
Absolutely. It's just wonderful, I guess, that we have so many different ways of practicing around the world. And I don't think any one is better than the other. It's just the way that we are, each system has evolved, I think. So I've got this picture of a lighthouse here because I guess the talk is called, Should We Demolish the Lighthouse? And that might seem a little bit, obscure, I suppose. But I really wanted to talk to you guys about my research and about how I got interested in leadership and this concept of lighthouse leadership. So the lighthouse is not a term that I made up. It's a term that came from a paper in the 90s by Cooper and Wakeham. And, they actually filmed live cardiac arrests, like they had a code pager, and when the code bleep would go off, they would run along and set up their camera and record these teams. And they discovered that the teams that were led by a leader who stood back and was very directive and hands off, these were the teams that had the best clinical performance. And that sort of research was duplicated in trauma teams. And in my mind, it led to this very common paradigm in medical emergency teams of this, they termed it lighthouse leadership, this sort of singular leadership paradigm. And I was teaching and training our maternity teams, and sometimes I think feeling a little frustrated that the leadership still wasn't perfect. And then I guess I started talking to and looking at what other emergency teams are doing, trauma teams and other emergency department teams, and they weren't necessarily only having one leader. And so that's really when I started becoming interested in this concept of shared leadership. And I'm interested, Demian, is that something you'd heard really before I started, I guess, journey or my foray into this concept of shared leadership?
Um, I would say for me, I had not heard of that idea, and and the lighthouse metaphor is an interesting one because it gives guidance and it's a single tall structure. But I think at least in the U.S. context, a lot of and also in Latin America where I have worked, um, a lot of the leadership metaphors have more to do with sports teams and military and other high performance teams. So whereas I hadn't heard of lighthouse leadership or shared leadership as a construct, I was very familiar with this idea that you have there, which is that, or similar to what you have there, which is that I'm not necessarily looking for leaders. Leader is not a person, but leadership behaviors. And so I always thought of, well, there's leadership behaviors amongst all team members.
Yeah.
And so I'm curious to learn throughout this presentation more about shared leadership, because I think I know what that means, but I'm always keen to learn from someone who's really specializing in the topic to understand what is it, what is it good for, and should I do it?
Yeah. So one of the other common terms for lighthouse leadership was the command physician in more a trauma setting. So very similar, but as I said, very singular, kind of the person in charge. And really, I started to question this as I started looking into this. Is this the best way to go? Because there's a lot of literature out there beyond healthcare emergency teams that show that distributed or shared leadership improves team performance. And so that's really what got me quite interested in this. And as you said, this, rather than necessarily looking at what we used to look at and what are the research before the noughties was looking at, it was like, well, who is the leader? And how do they lead, and focusing on that to improve leadership. And it's interesting because you still see these papers out there, like who is the best person to lead the trauma team? Is it the emergency physician or is it the trauma surgeon? And papers and papers getting written about this, or how should they lead? What kind of style of leadership should they have, et cetera, et cetera. So, and I think there has been a recent shift in, as you said, thinking about what those leadership behaviors are. And we call that, it's called in the literature, functional leadership. So more about the what of leadership. So what are those leadership tasks or functions that need to be performed? And it's interesting because when you look at what needs to be performed from a leadership perspective, you can start not focusing on that one person who's standing at the end of the bed, but start looking at that whole team, and it really broadens the lens through which you're viewing leadership. You were going to say something there, Demian?
Yeah, so I'd like to invite people who are joining us internationally here to comment on the chat. What do they value in a leader and in leadership behaviors when they're thinking about acute care teams or healthcare action teams?
Yeah.
So as Sarah keeps on describing here, I invite you to start commenting for what you see as valuable and what you see as working.
One of the things that's interesting, Demian, in this regard is that there has been a little bit of a shift. So if you look at all these tools that get developed to rate teamwork and leadership in trauma and emergency teams, until extremely recently, they all the domains or the items are like, the leader did this, that, or the other, or does this, that, or the other. And a more recent tool, like the Petra tool, which is an obstetric emergency team assessment tool, it's the first one I've seen that actually talks about the leaders and has a much more inclusive, I guess, broad-ranging way to assess leadership. So it can be something like those tools that really focuses in on one person rather than necessarily thinking about the leadership behaviors in the whole team.
Very interesting. And it's already getting me thinking about what are some of the negative leadership performances that we're encouraging through simulation, and what's the relationship between your experience in sim and experience in the healthcare system. So hopefully
Yeah.
we'll get back to that towards the end.
Anything coming up in the Q&A?
Not quite yet, but I'll let you know as we get to that.
Cool. So I guess part of that journey that I started on was seeing that there's all this literature and there's so much out there about shared leadership improving team performance, and particularly in teams that are very similar to our healthcare action teams. So high stakes, time critical, very diverse team members with specialized skills. These are the teams that benefit from shared leadership. And they're very similar to the teams that we work in when we're responding to healthcare emergencies. So I thought, well, how are we actually sharing leadership? So as you mentioned, I did a systematic review and used a conceptual framework that had been developed in actually the educational literature, looking at how is leadership shared. And they kind of came up with these 3 forms of shared leadership, which were really quite evident when I looked in the healthcare action team or emergency team literature. So my plan now is just to kind of go through some of these types of shared leadership and comment on what we found about them and have a discussion. And I really like to hear from those who are listening about whether these things are sort of resonating with them, and are they recognizing these forms of leadership, sharing leadership that perhaps they didn't really think of as shared leadership in the past.
So the early comment here, Sarah, one of them says, look, it really depends on the situation. I do support shared leadership, but sometimes Lighthouse is necessary. And I think I've heard this a lot of times, like, yeah, that sounds like a nice idea. We'll share and be all happy, hold hands, all interprofessional, but sometimes I'm interpreting here, but sometimes the doctor just has to be in charge. Sometimes the surgeon needs to take control, et cetera, et cetera.
Yeah, well,
another comment says, well, it depends on what's happening. Again, the situation would dictate who's on the team, what's their expertise, how well do they know each other. So it seems like the question for people isn't, is shared leadership good or bad, but it might be, when should we have it? When should we not have it? So maybe you could tell us about how that, I'm very interested in both what you found in your study, but also how you came to these questions and how you tackled them.
Yeah, well, we'll move on, and I think we'll address some of those concerns or those comments as we go through what we found. But there's still a lot we don't know. So I guess the first form of shared leadership is this planned shared leadership. So these team structures that do typically have a medical team leader and, say, a nursing team leader, like a trauma team, and they're influencing the team. So maybe just to take a step back to define what leadership is, it's all definitions of leadership essentially have that they include a process of influence that's getting the team towards their team goals. So these types of leadership sharing arrangements are really about trying to offload or divide the load of the leadership functions between 2 or more people for the purpose of improving that leadership. And typically the papers that describe this sort of leadership sharing were a medical team leader and a nursing team leader, and the medical team leader doing the clinical stuff and the nursing team leader using their expertise in logistics and communication to kind of manage the resources in the room, manage the communications of the team, and think about the external communications as well. So a very, I guess, common form of shared leadership. Interestingly, even though I say sort of the nursing team leader being the logistics and communication, there are increasing reports now coming out of nurse-led codes, for example, where in fact a nurse leader is leading the actual algorithm, ALS algorithm, and the medical team leader is taking a very different sort of leadership functions role. And the other sort of area that we saw shared leadership planning, planned shared leadership is in these very, very complex teams that actually ended up with little micro teams. For example, extracorporeal life support, where you have an airway team leader and they lead their little airway micro team, an ECMO team leader managing the ECMO team, the resus team, and then this primary team leader who's overseeing them all. So when there's just so much leading to be done, just dividing it up into little, I guess, subsections of leadership to try and improve the team leadership overall. So, oh, I can't hear you, Demian.
This resonates with me, Sarah, and it makes me think that, you know, I've worked in several trauma centers, and not necessarily the most liberal or progressive, and certainly the trauma team leader is always a physician, but really, who are we kidding? It's the nurse that's telling you, we're doing this resus in this room, or I think they need to go straight to the OR. Don't you agree? And
yeah,
so it makes, you know, I think that really is there, that maybe what's confusing or interesting is that it's really not who is the team leader, but what's the leadership being done, and why do we have this need to call, you know, to call someone the leader? What is that doing?
Yeah.
But
Well,
all these, you know, these, to me, this is very helpful because there are these sub teams. They do have leaders, and yet there's probably some other overarching leaders going on around there as well. They're just not getting the credit.
Exactly. So I think it comes down to ultimate authority and that traditional hierarchical structure that we have in healthcare, that we need to have someone, the buck stopping with someone, or someone being able to say that final word. And so shared leadership doesn't necessarily, these are not mutually exclusive. You can have a hierarchical leader and still have shared leadership. But ultimately, I think in medicine, we have this desire or need, and whether that's real or not, I don't know, to have that one person who is at the top of the Christmas tree kind of thing. So, you know, the interesting thing about this, Demian, was in all the papers we looked at, there's very little evidence to suggest that this improves team performance at all. The data was, the studies are not very methodologically sound. So the kinds of studies that we saw here was like, oh, we introduced a nurse trauma leader into our team and a few things got better. But that nurse trauma leader also did a whole heap of other quality assurance activities within the department, and did education and training and rehearsal. And so whether or not this actually does improve team leadership or team function, I think is a big unknown. I think we all like it and we think it makes sense, but the data is not there to just necessarily suggest that it actually does improve team performance, because there is an additional burden that comes with having several leaders of communication and coordination. And there's always the risk that the primary goals, say, of the airway team leader and the ECMO team leader are going to be in conflict. So when you're dividing leadership functions up between several people, you have to work extremely hard to make sure that you all have that shared goal and you all have the same priorities. So it's interesting.
Communication and coordination become that much more important when you divide out the.
Yeah, absolutely.
Tasks.
Yeah. Okay, I'm going to move on to the next form of leadership, and I think you'll of leadership sharing, which I think you will also find familiar, Demian, working in a hospital where you have residents. And Gron, whose framework we're using, called this intuitive working relationship. So what that kind of means is it's not like a formal arrangement. It's not written in policy or a guideline. It's not necessarily organizationally kind of sanctioned, but it's just the way that people practice and we all understand that this is what happens. So sorry for the Australian terminology here, but it's a situation where you have, say, a resus going on and you have an attending or a consultant who's actually kind of, that they're in charge, but they actually delegate the leadership of the team to the trainee or the resident or the registrar to let them lead the team. And so this, as some of our listeners kind of mentioned, is a very dynamic thing, and how much leadership we cede to this trainee depends very much on what their level of experience or expertise in, how much we trust them, what the acuity of the patient is, how sick they are. So it's a very interesting form of shared leadership, which is kind of a bit more vertical, but you're sharing up and down a vertical chain rather than necessarily laterally throughout a team. And so the purpose of this is very much not to improve overall team performance, but to train that person in becoming a leader. And the consultant still retains that hierarchical authority and has the ability to remove or give to the registrar that ability to perform those leadership functions. This resonating with you?
Completely, and also I think aligns with our competency-based assessment scheme of entrustment, and totally agree that trust and the relationship, I think I like that you have the bidirectional arrow, because part of at least my style in supervising, maybe you do the same, is making sure not only that I'm watching for what I can support, but that I'm also opening up the, hey, let me know when you want me to step in, or let me know. I think that it is an interesting and complex dynamic to have that supervisory and shared leadership in the working relationship. Thinking about work that Walter Epic has presented here in a previous webinar, it makes me think that completing a resuscitation without losing the authority of being that team leader is a form of feedback and a form of assessment that trainees are looking for. Maybe it's similar in the operating theater, that you were able to complete the appendectomy or the salpingectomy or the cerclage on your own and without assistance, and et cetera, et cetera.
Yeah. So no data on how this affects team function or team performance that we could find. And that's, in my mind, this is an area ripe for further research to understand the impact that this sort of sharing of leadership with a junior practitioner has on team function and team performance. So interesting. I'm just going to move on now to the other third major form of leadership sharing that we found in the literature was around this spontaneous leadership sharing. So that's when you might have a very traditional team with a singular team leader and a team, but actually whether it is real or just perceived that the team leader is not performing the leadership functions that are required at that time, is that team members will start to exert lateral influence on each other or lead each other, or in fact start leading the team leader towards the team goals. So very, very common, and I think almost ubiquitous form of leadership sharing. And again, people are contributing leadership functions because they want to improve the leadership, improve the team function, and decrease the leader's workload. So again, interesting, the data on this very much showed that has the potential to help and hinder teamwork. So and it's interesting because you can kind of get into this real conundrum of thinking about leadership and followership, and actually followership might be good shared leadership, and understanding when you should contribute leadership and when you shouldn't. Mm-hmm. And it kind of, when you start thinking about this, you realize the falseness of this dichotomy of leaders and followers, right? And you kind of realize that everyone potentially is a leader, but they need to choose which leadership functions that they should perform and when to perform them. So this happening when you're leading resusces, Demian?
Yeah, I really makes me think about parsing out subtasks like in your previous sub-team area. And in a way, part of what I think is in play for me is the burden of communication and coordination.
Yeah.
So if the airway team is doing well, all they need to do is inform you and they can make their own decisions, and you trust that they're taking care of the problem and will let you know if there's an issue. But if they're really problem solving on their own and aren't letting you know, then you can't help them, and also you don't know what's happening. So that, I think that double-edged sword is definitely there. And I think it's similar. It sounds similar to what I've heard described in the anesthesia side of the curtain and the surgical side, and also the perfusionist side. So it seems like all these acute, complex, multi-organ situations call for this. But I'm also thinking about other kinds of settings where it might also be important, like coordinating complex care, a lot of outpatient transitions of care. I really think it's likely to be as important, if not more, in other types of settings, even though my own practice is very focused here.
I'm glad you brought that up, Demian, because in fact, this research has been very, very focused on the acute emergency setting and teams responding to acute emergencies. But there is so much literature and need for more focus really on shared leadership that's not in these acute emergencies. It's fertile ground for further research really of what's going on. And there are people starting to look into this all around the world with respect to, just routine operating theatres, activity, for example, and the types of leadership sharing that's going on in those, and very much management as well, in healthcare management.
So from the Q&A box, the question is this not similar to sharing mental models and having two-way communication between members of the team? So where do we, how is this different than a communication scheme? Like, why are we talking about it separately here?
So the key difference really is around that influence. So shared mental models and clear communication are vital, really, and a vital enabler of shared leadership. But I guess the main differentiator of shared leadership is someone influencing another individual, getting them to do something to progress towards that goal. So, and it is nuanced, right? And so it's interesting to kind of make that line of when someone says, oh, should we call the code team? Is that influence, or is that just raising awareness? And I think that there is some subtlety in that, as in like a nurse kind of saying, should we call the code team? And like, you need to call the code team. The message is actually there, right? As opposed to just pondering, I wonder if we should call the code team. So in my mind, one is exerting influence, and actually, even though you're asking this question, you are saying you need to call the code team now, as opposed to just pondering it. And that's where the line is, which is super subtle, I agree, and a very, very fine line. Does that kind of make some sort of sense to you? That's how I see it anyway.
Yeah, I think when you said authority, I think that really struck a chord, because I've been thinking about adaptive leadership, which is kind of giving names to moments and concepts as a way to move an agenda forward. And I think in a way there's this important thing that happens when you say, okay, we're going to have this, I'm going to lead this part, you're going to lead that part. You're calling someone a leader of a part of the resuscitation, whether it's pre-arranged, or in our setting, we use stickers to mark who's the airway person, who's the trauma team leader. You know, when you get that authority, people know you're making decisions in that area, not alone. So I think that, you know, in a shared leadership, in an explicit shared leadership model, authority, rights, responsibilities would come along with that.
Yeah.
So I think that the idea of authority and alignment and credit where credit is due, I think this is all making sense, that there probably is more shared leadership out there than we think, even if our systems and our personnel is calling themselves the sole leader. There's probably more shared leadership happening.
Yeah, for sure. And I think it's when you start looking for it, the more you see. But I mean, it's interesting. So there was, you know, I think I'll explain more about spontaneous shared leadership. And I just want to do a time check with you, because I think we're going okay, but I wanted to move on to talk about, because the next study that we did was specifically looking at this spontaneous leadership sharing and its relationship with team performance and how prevalent it was. So
yes, maybe you tell us a little bit first about how you wrapped up this study and kind of decided where to go next. And that'd be great.
So I guess, you know, the so what of it, you've described something that everyone's just going, yeah, of course we recognize that, and that's there. But, you know, what does it matter? And I think for me, it matters because of team performance. So what is driving team performance? When should we share leadership? As your participants, as our listeners said, well, when is it okay to share leadership? When is it going to be helpful? When is it actually going to hinder us? When should I be the lighthouse, and when should I be that more empowering leader? And understanding the answers to these questions, I think, is key. And so this was a little moment, sort of, I wrapped up my fellowship and went from the beautiful snowy climes of Boston and back to the hot, terrible Australian summer, and then kept.
But you finally got to be living right side up, without your head down all the time.
Yeah, exactly. It was a bit, I've just only got over the headaches now. Sorry for the gratuitous beach scene. So I guess I wanted to ask then more specifically about my area, or how much shared leadership is there in maternity teams, and what was the association between team performance? And so that's really when we moved on to this next study, where we looked at maternity teams, simulated maternity teams responding to a postpartum hemorrhage, and I don't know if I'd volunteer to do this again, but we transcribed every utterance of every team member, and we coded it as leadership or not leadership, and then we divided the teams into those teams that shared a lot and those teams that had a more singular type leadership.
I mean, I would just say a priori, so postpartum hemorrhage, right? The baby's delivered, the mom is bleeding to death. The midwife or surgeon has to intervene in the perineum within the uterus. The patient needs to be transfused. Maybe you need to move to an ICU context. Maybe the baby still needs resuscitation. So to me, it's a complex, multi-organ situation, and based on my intuition, shared leadership would make sense. And also in the moment of stress, I could see how sometimes some leaders would say, I'm going to take command and control and be the lighthouse. But I can't imagine that would be more effective. So just wanted to add that in terms of, I like the context you chose, and it seems perfect for exploring how people lead in that critical. And if I got any details, wrong, fortunately, I don't deal with too much.
So just to clarify, these were postpartum hemorrhages that occurred in the birthing suite area. And the teams were like 5, 6, 7 team members responding, baby's out, woman is bleeding to death, etc. And yeah, so I was interested to understand is that one person taking, how much leadership sharing was going on spontaneously, and was it helpful or harmful? And this is one of the results really where we looked at the overall teamwork score using a couple of validated tools, and there was no difference in the overall teamwork score between teams that had Lighthouse Leadership or more Lighthouse Leadership versus teams which took a more distributed or shared leadership approach, where people were making decisions on their own and influencing others towards the goal. So interesting. So no difference at all.
Why do you think there was no difference?
Maybe I'll get to that in a minute.
Okay.
Yeah. So because we did a couple of clinical comparators as well, just to let you know that we also looked at the checklist completion, and again, no difference in the number of things that they should have done, getting oxygen on, getting drips in, sending bloods, fluid resuscitating, giving the uterotonic drugs, all that sort of stuff. No difference in the clinical checklist. But contrary to what you were kind of expecting, the teams that had a very distributed leadership or shared leadership pattern actually were slower to do the critical thing that they needed to do, which was transfer the patient to the operating room because they had ongoing bleeding. So they, whereas the more singular leadership teams got that one thing done quicker. So, so this is super interesting. And then now you ask, why do we
half the time almost?
Yeah.
Wow.
Yeah, so I think there's a couple of explanations for what is going on here. And firstly, to say that this is a retrospective study and it's just observational, so we can't apply any causation. But as a person who watched those videos about, it feels like 1,000 times, I think that there's a couple of things going on. I think, firstly, to note that even the very singular leadership teams, the most dominant leader, actually the most leadership they did was about 75%, 80%. So there was still a large proportion, even in the lesser sharing teams, that other people in the team were performing leadership functions as well. So, and the teams where the leadership was very widely distributed were often teams that were flailing. The designated leader was really flailing, and everyone was like chipping in and trying to help get the team to where they needed to go. And so we saw both of these sorts of things of, shared leadership helping a poor performing team get better, and shared leadership also sometimes confused and duplicated work that was going on. So not to be critical of any specific specialty, but you might have a team leader that was an obstetrician who was doing a reasonable job, and then say an anaesthetist sort of coming in and going, have you got 2 drips in? Have you done this? We should need to do this and this and this. And they were actually duplicating a lot of the work that had been done, which is a failure for those 2 leaders to have coordinated and communicated. And so then you're duplicating and making the teamwork inefficient. So we saw both of those.
So on the comments here, somebody said, could it be because of a seniority experience? They're better at prioritizing. One of the things I've been thinking a lot about is gender and racial biases, and how does that factor in?
Look, we didn't look at gender specifically or race or anything like that. I think this was a reasonably small study, so we couldn't go into the details of that. But I do think that the quality of the actual designated leader has such an influence on team performance that it makes a lot of the other stuff less less important. And so what I'm trying to say with that is I think what we want to get to is a sweet spot, right, where we have designated leadership that is so effective that the rest of the team doesn't need to pitch in and perform leadership functions. And for some individuals, perhaps that one person is capable of doing that, but in other individuals, perhaps they need some help. The most high performing team that we had in this study of 16 teams was actually a team that had a doctor, an obstetric doctor who performed 75% of the leadership, and a midwife who did 25% of the leadership, and not a single other person. They just did such a good job. There was no other leadership functions in that whole team that were performed. So, you know, I wonder if there's a sweet spot, right? That maybe one person, it's just too much for them to cope. But once you start spreading it out too far in your team, the leadership, then the coordination, the communication burden gets too high. So, you know, maybe there is a sweet spot that trauma teams have actually come to intuitively with a co-leadership model.
Well, I think in the questions and is embedded potentially the idea that maybe there's a third axis, that it's also the quality of the leadership. It's not just whether or not there's sharing, but also how effective is it?
Yeah. Well, the more effective the designated leadership is, the less there will be a need to have spontaneous leadership sharing emerge from the team. And I think that's where you want to aim for. Not that you ever want to stifle your team members helping you out or forbid that, because no one is a perfect leader, right? But where is that sweet spot of being effective enough to not need others to perform those leadership functions?
That's great. That's starting to come together for me, that if you're open to shared leadership, it could rescue you when you're not doing too well, just the right amount. And I finally also, I think this is why I love the Meet the Author series, is that, you know, when I first looked at the paper, I thought black and white, well, shared or not shared. But now I'm looking at, now I'm looking at your data here. It's like low sharing, high sharing. That really speaks to that idea that there isn't no sharing.
Yeah, no, there's not. There's not. There's always some sort of, and as you know, leadership functions performed by others within the team. I think, from what I've seen. Yeah. So this is what we got, really, was that there is shared leadership universally. There was always shared leadership, even in the teams that had low sharing, but we didn't see in this data association with team performance, either from teamwork, and in fact, too much sharing seemed to, and whether the quality of the leader was the main moderator there or confounding factor, that you had a really good leader, they got on and they got that patient to theatre quickly, and the rest of their team didn't feel like they needed to pitch in and contribute shared leadership to the leadership. So I'm looking at the time and it's about 10:02. So I was going to kind of finish up, and I can say I don't think that we should demolish the lighthouse yet, because as someone said at the very beginning of this talk, sometimes maybe we do need the lighthouse. I don't know, but I do kind of think that maybe there is a sweet spot. And so the study that we've just wound up is this study comparing a co-leadership model or a dual leadership model, so a model of a medical team leader and a midwifery team leader versus our traditional singular team leader. So I'm super interested to hear from you guys, because we haven't analyzed any of the study yet. I don't know what we're going to find.
So, I mean, I think one of the other questions is being raised, Sarah, is to what extent do the observational studies just show us the worst possible performance without really formal training? So if you're intervening and really saying, hey, this is the way to lead, have a singular team leader, versus this is the better way to lead, what's the quality of the education, what behaviors does that turn into? I think that's very interesting, because now you could say, okay, well, what's modifiable here?
Yeah.
So
And
is
so,
that how you're doing this current study, is you're
yeah,
teaching
so
people
we
the right
absolutely did
way?
focus on actually, in parallel with designing this study, we actually redesigned our whole training program on, well, what exactly should a leader be doing, and what are the steps that they should do when the team comes in? How do they allocate roles? What are those roles? And we made it really, really granular, because I think our misstep previously in teaching and training with teamwork and leadership is that we didn't even have in our mind, well, what is the perfect way to lead in a maternity emergency? And so really spelling that out granularly and training through we use games, we use rapid cycle deliberate practice before we put them into the simulation, so that we would get them to a point where their leadership in each model was exemplary. And now we're going to compare those two teams. So this will be interesting.
In terms of fostering psychological safety, people are asking, how does that play in? Is that part of the training as well?
I guess I'm not entirely clear with respect to what they're asking. As in, of course, in our sim course, we spend a lot of time pre-briefing for psychological safety, and that it would be part of any standard simulation course that we would run, and it's very important.
I'm only interpreting, but I would assume that team leaders can affect psychological safety, foster within their team to encourage.
Yes.
And I think it goes back to that fine line between encouraging people to speak up and naming a designated leader. So I think potentially we're in that same discussion.
Interestingly, you say that, because one of the actual defined behaviors that we're training people to do is what we call a recap. Walter would call that team in-action reflexivity, but to go through a structured recap, and for the designated leader to always end with, and can anyone think of anything else, or are we missing something there? So adding in some structured team leader humility to enhance psychological safety and give that moment for people to contribute, so they're not interrupting and duplicating later. So that's part of what we've been doing as well.
So right now in this trial, you've completed the data collection.
Yeah.
Any hypothesis from your end, or
I have no analysis? Idea. We've just started rating all the videos now, so I'm not going to predict things, and I'm not sure what we're going to find. So I'm interested to hear. I think we've got a little poll. Is that right?
Yeah, I mean, in this country, we've had a lot of issues with pollsters, but let me just still share this poll here and see if the people are willing to answer here and tell us what do you think Dr. Janssens and her team are going to find in this current study.
Yeah, looking at one leader versus two in a maternity team.
So let's see. You should be able to, everyone should be able to vote now.
Is this a poll that's been, it's not fraud in this poll, Demian?
People are completely free to answer. Hopefully they will, in this case, they won't vote later. So we've got, so far, 10 people have voted. So I'll wait a couple more seconds and see if we get a couple more votes. And let me share the results. 13, 14. That's pretty good. 70% sample size here.
Yeah, good.
75, 85. Very nice. Okay, so here we go. We'll share the results. So 75% think that you'll have better team performance, whereas 5 think there's be no difference.
Yeah, so I don't know yet, and I'm being very scientific about this and keeping a very open mind. What I do know is I've had a sneaky peek at people's evals of the course, and they love shared leadership. It's been overwhelming support for it, which will be very interesting if we find no difference or worse team performance, and it'll put us in a really interesting position.
I mean, I think that's what's so great, Sarah, is that even as someone who you believe in this and yet you're staying skeptical, because I mean, I'm thinking you don't want to waste people's time and lead them in the wrong direction with a fad that doesn't really pay dividends.
Yeah.
So I'm so glad you're studying it. I
Yeah, I
want to
think,
give you one more comment here, and then we
okay.
will move towards wrapping up. So I'm intrigued by the dual leadership model. Our facility trains cardiac arrest teams, nurse only, as though, and the nurse is the team leader. But there's the assumption that when the medical officer arrives, they'll take over a number of roles and responsibilities. So as there's no medical officer rostered to the code response, we can ensure that the MOs who attend are all the same level of training. So we have to train the nurse team leader. So be interesting to work with our medical officers to formalize that dual leadership structure. It sounds
Yeah,
like to avoid that in the moment conundrum of handing
yeah,
off when it may not be appropriate. So I think you're getting a lot of very good response here in terms of the real world applicability to a lot of our action teams. And I think people are really trying to do their best. Um, and would love more guidance on what's good. So
yeah. Well, there's a lot of information out there on shared leadership, not necessarily in healthcare teams, but about, if you are going to set up a co-leadership model, there's even different types of co-leadership. But I think that it's like a good marriage. If you're going to have a co-leadership, you have to have frequent communication, you have to trust each other, and you also have to draw on each other's strengths and expertise in getting to where you want to go. So that's what the literature outside healthcare teams are. And I guess the marriage analogy is one that kind of resonates with people. You got to really trust, communicate, and yeah, know each other's strengths and weaknesses.
yeah. Well, thank you so much for sharing. Do you have any closing thoughts or any other slides that you wanted to share here?
No,
Otherwise,
no, I think that was the end. I'm going to stop sharing now. And I guess I just encourage people, if they find this topic interesting, to think about their own setting and maybe start a body of research. I never thought I was going to be a researcher, but my clinical interest in making teams function better kind of led me along that way. So I'm grateful to CMS, and I'm grateful to my organization for supporting that. And I'm more grateful even to my amazing PhD supervisory team, Stu Marshall, Robert Simon from CMS, and my boss and long-term mentor, Mike Beckman.
well, it's been a pleasure to see you develop the ideas and take them forward both in Boston and in Brisbane, where I've got a chance to visit. I know that you're interested in people connecting with you, so
Yeah.
you may reach out to Dr. Janssens by email or through Twitter, as well as staying in touch with us at CMS. Feel free to reach me as well, and I can connect you. Come back next week on November 11th. We'll be having an open forum. We can continue our conversation around teamwork and education, as well as quality and safety. In December, I'm excited about an exciting brief feedback seminar that Janice Palaganis and myself are putting together just to increase all of our game in giving and getting feedback. And a number of other opportunities are available through the virtual learning that we're offering now at the Center for Medical Simulation. So reach out to us individually or as an organization, because we would love to work with you. And thank you so much for supporting the weekly webinar. Sarah, again, thank you so much
Pleasure.
for being here. I really feel like you have been here as well. And keep us posted on how the study data evolves, because now you've got me really wondering what to do and how, and maybe starting my own personal experiments. So thank you everyone who participated and who commented, and I look forward to seeing you next week.
Yeah, thank you so much, everyone.